Bismillahirrahmanirrahim. Today, maybe we can make a small introduction because I have been asked many times about the bed city, if there is any introduction or basic information. So let's see like this case, and who work with the bed city know that when you have a case, you work in the workstation like this, and you check the CT, and you check the bit and the fused image of bit and CT, and there is the MIP image that you can just check all the lesions. Usually, the indication of bit CT, they ask you for staging, or for example, restaging after therapy, or to assess specific or to solve a specific issue regarding a patient. This is like a summarize what you have, what the question you will be asked when the clinician give you the request. Anyway, let's see this case, and I like always interaction. So even with a few candidate today, but I would like the most important for me just that you share with me in interactive mode to be active with me. Okay. So in this patient, the most important when you go through the case of BED-CT, that to know what is the normal and what is the abnormal, because you know that there is some areas. Let's take the case from up till down. That some areas should have uptake. So not any uptake in the case, it will be pathological. For example, let's go from the brain. Maybe the image is not very, but can anyone respond in the chat? Is it the image quality is fine? I wish that it is fine because I cannot modify it. Anyway, you are starting with the CT. Check if there is any abnormality, for example, in the brain. When you go to the PET image, you will find that the cortex in the brain have already normal uptake, right? Is it normal, physiological, or pathological? Let's go together, check the brain, and see that the cortex have uptake. Is it normal, physiological, or pathological? Normal, yes, Abbas, thank you. Why normal? Because the brain is maybe the most highly metabolic organ, have the most active metabolism in the body, the brain and the heart. So always when you check the brain and the heart, you will find that the metabolism in both sides will be very high. So this is normal for you. That's why when you have a brain tumor, it's very difficult that you can detect it as a primary. That's why the PET-CT in the brain tumors as staging, initial staging, is not very preferred. Maybe sometimes just incidental, but to be the first instant initial imaging is not preferred. Sure, the MRI will be the best. Okay, so after you check the brain, you are going to check the rest of the body, and sure that carefully check the CT first, check the PET. You will check any active lesions. The active lesion usually it look with black or with abnormal uptake. That in the image it should be like a black, like you see here. In the fused image, it should be colored, like you see here. And the color scale, you can change it according to the workstation you work with. Okay. Anyway, you are going to check the image the most important when you go to the neck that you check for the lymph node metastasis. And here there is a very importance that you go through the fat spaces in the neck and check carefully if there is any lymph node enlargement. One of the most important indication in PET-CT that you check for lymph node metastasis or lymph node infiltration. Lymph node infiltration like lymphoma and leukemia and so on. Lymph node metastasis from any tumor. When you go in this area, in the lower neck, is important to check with something called brown fat. You can see that there is high uptake in this area, and in the corresponding fat, there is no in the CT, there is no what? There is no soft tissue masses, there is no lymph nodes, there is no lesions. So when you check in this area, you will find something called normal finding as brown fat. So this is one of the important pitfalls. They like to show you in the exam as MCQ or as even in short exam that they can just show you something like this brown fat and to check that is he want to be sure that you know that is just normal finding. In the lower neck, it will be difficult because also if you have already lymph node metastasis, it will be for you challenging that you can differentiate between the normal fat and the abnormal lymph nodes. That's why the importance that you should know the anatomy and you should know the neck space as well. And you should know also the how to look the lymph node when it is infiltrated. It should be it appears in the CT. So who will read the PET-CT, he should have good knowledge of the pathology and the anatomy and what is regarding these issues. Okay. Then after you go down, you clearly go through the mediastinal window to check all the lymph nodes and sure that you check for mediastinal masses, check for any soft tissue masses. Again, the axillary, especially in lymphoma, you check for any axillary lymph nodes, or in breast cancer, you check for any metastasis in the axillary region. So when you go here, do you see any abnormality in this case? I see always like we have permanent stars like Ivan and Abbas and so on, and there is some new stars in our session today. So anyone would like to join, just write in the chat, and he can interact with us in this session. So do you see any abnormality here? What is the abnormality? Yes, there is a mass. So there is a soft tissue mass. So this is abnormal finding. And when you go to the PET, you can see that there is very high uptake. And this is now the importance that you use something in the workstation with measurement. You check for how to measure the SUV. So just you click here and you go and you put your arrow here. It depends on the workstation what you are using, and you check how much it measures this lesion. Usually the heart have, as we mentioned, this is the normal FDG uptake of the heart. Yes, so this is normal, and in the lung, this is abnormal uptake. Yeah. Okay, Rabab, thank you. Ivan, thank you. So after you check for any masses. Here the importance when you have like lung cancer as is initial staging, and they like now for the lung cancer to use PET-CT as initial modality. So in many places in the world, they like to start if just they see like lung mass in X-ray even, they request directly PET-CT because maybe they mentioned that the best modality for initial staging right now, it will be the PET-CT. For example, this patient, he have this mass, and then they would like just to direct the patient to PET-CT to check for any lymph node metastasis, any other lesions. Let's check it when we reach to the lung window. Then you check for any N metastasis, N lymph, nodal metastasis, or M metastasis. So you check for the T and N and M. T in M staging, T for the mass and the metabolic activity of the lesion. And if there is any other lesions, then the N for the nodal metastasis. Then finally for the M staging, if there is any other lesions, for example, in the liver, as here lung cancer, so you will check the adrenals. It will come now. And there is like some incidental lesions that could appear while you are checking the PET-CT. For example, here, this one, it could be a renal cyst as incidental region, so you should report it and also make like check the metabolic activity if there is any metabolic activity through this lesion. And finally, you are going to check maybe it's metastasis, maybe just incidental lesion. Okay, like you have atherosclerosis through the aorta, so you should check and comment upon this. And some of this incidental lesion could be very critical for the patient. If you find a gas, if you find something like emergency. Okay, so this is the quick introduction. Let's go for like one or two cases from the So, for example, this patient did bone scan. Do you see any abnormality in the bone scan? No? Okay, that's good, Ivan. So there is normal uptake in the bone scan, probably no abnormality in this case. Then if we go to the CT, do you find any abnormality in this selected image? Right or left lesion? Is it right, left, or both? Maybe in the right side, maybe you suspect that there is a sclerotic lesion. Okay, so after he did the PET-CT, you can see that there is, yes, there is a lesion in the right femur, and maybe in the CT wasn't very easy to detect, not very easy to detect. In the PET-CT, you can detect it easy, and you can see that there is M metastasis in this patient. This patient already, he is a breast cancer patient, and this is the MIP image of this case. So there is, in this left breast projection, there is some uptake, and here the M metastasis, which is indicative that the patient is stage 4. So this is the message that you take, that some cases that the PET-CT affect the staging or the restaging, that it can help as interpretation. As you see in the bone scan, for example, wasn't in this case, was like almost free. And the CT, when he did CT for this patient, it was very difficult to detect that there is a femur lesion. But after he did this, you can see easy that there is high uptake. That's why when it is affected the staging. Let's take another case. Again, in this case, just on one image with the MIP, you can see that there is try to describe what do you see. So there is axillary lymph node metastasis. Muhammad, thank you. And probably there is a mass lesion in the breast as well. And the axillary metastasis, maybe it is multiple. So you know that they have, according to the pictorialis minor, they have 1 and 2 and 3 groups, right? So maybe there is multiple lymph node metastasis. That's why it's important to check the axial image of the CT and the PET-CT, that to check which group is involved. And there is liver metastasis, and probably there is bone metastasis. You need to check the raw image or the axial image. When you go to select the axial image in the breast, you can find easy that there is left breast mass and there is lymph node metastasis. This patient, another patient, he did ultrasound, and he find like small, who did the ultrasound, find like very small nodule, and he take like a biopsy from this nodule, and it looked like invasive duct carcinoma. They suspect that it could be there is lymph node metastasis, so they did PET-CT, selected for this patient, and they did PET-CT. So what do you see here? Yeah, there is abnormal uptake in the right breast, which indicate that there is could be lesion, yes, and there is could be maybe there is lesion in the vertebra, but to be honest, this can happen as artifact, that the uptake in the heart, it could have like artifact with shifting to the adjacent vertebra or adjacent organs. So sometimes you should check clearly what it could be. Is it vertebral metastasis or just artifact from the heart in general? So this patient, he just was doing this PET-CT because he already have primary ovarian cancer. Then they find this as incidental finding. He find this ovarian cancer as another second primary. So this was the surprise in this case. He wasn't breast cancer. He just find it as another associated cancer. Let's check this case, this patient did PET-CT and he was breast cancer and he treated, but he did PET-CT as in follow-up. So what is this and what is this? This Ivan Rabab, thank you for the sharing. Ivan, so this could be axillary lymph node, and what is this? No? No? No, Muhammad? Abbas, yes. Rabab, yeah. So it could be injection site or extravasation. So there, yeah, it could be injection site or extravasation. I just want also to tell you that sometimes the marrow appear like hyperplastic or it appear like more active, and sometimes you can see the muscles and the skin is a bit hyperactive. So this means that maybe this patient he did some effort. Anyway, so this is artifact injection site, and this could be axillary metastasis. In this case, is important carefully to check the axial image to check what it could be. Okay, let's check the axial image in this patient. When you check the axial image in this patient, we find what we have here. We find the axial image of CT and the axial image of the PET. So this corresponds to this. So do you think in this case that this lymph node, it could be pathological or not? From the CT image. So very small lymph node, yeah, is not pathological. So now you need interpretation for why this lesion have very high uptake. And in the CT, you don't have something that say that it's pathological. It look like normal or maybe just reactive lymph node. Yeah. So that's the issue, that sometimes there is what is called artifact. That there is artifact from extravasation at the injection site, as you, I think Muhammad, who Abbas, no, Rabab, yeah, Rabab, as she told us that it could be extravasation. So the tracer just have extravasation and make artifact in this area. So the most important when you make interpretation in the PET-CT to check carefully what is normal and what is abnormal. So there is some important pitfalls. Not every shiny or hot spot you can consider it as a cancer. Okay, let's go to another home messages. So I am focusing on breast cancer in my examples in this session tonight. So this patient has breast cancer. So you can just describe that there is left breast mass and there is infiltration. Hiba alaikum salam wa rahmatullahi wa barakatuh. And there is infiltration that maybe there is even skin thickening and so on. When you go to check the fused PET-CT image, yeah, what do you think? You think that it is highly metabolic lesion. So it take very high uptake. That's good. Now, when you go to make interpretation for the spine, you find this appearance. So there is high uptake in the spine. So it could be metastasis. What do you think? there is bony uptake. So it could be metastasis, could be anything else, or just metastasis. Yeah, but if in case that you say degenerative, Rabab, you say that maybe there is degenerative changes in the other vertebrae. So why exactly this vertebra take, especially the posterior element, and the other doesn't have uptake? So there will be discussion about this, right? Abbas, the age of the patient is important. So I think this patient looks like old patient. So it's a bit far to be, yeah, osteoma, as you mentioned. Metastasis will be the best option in this case, but there is any other option from this appearance? Yeah, the question will be, I should to, the answer it will be, I should go to the CT image and check for the shape of the vertebrae, right? So go and check for the shape of vertebrae clearly without affection of the bit color. Don't be affected by the bit color. So in this case, without affection of the bit color, in case that it could be not metastasis, HIBA perfect. Nice, perfect HIBA. So budget. Budget is one of the important pitfalls that it could happen as similar to the metastasis. Sure that metastasis still will be option, but just to know that there is not everything, it could be just metastasis. So you should eliminate the color and go to the CT image and check carefully. Yes, there is thickening. And this is one of the important criteria for budgets, that you find there is enlargement of the bone and thickening of the cortex, coarsening of trabeculae. So this is could be benign budget. So with the benign trabeculation, and there could be, yeah, budget disease. So let's go to the home message in this case. So you should be aware of the neoplastic mimic lesions that make you confident to not make upstaging and sure that you will affect the management. So not every colored spot is cancer, and the reverse is true. Yeah, that's a good question. So you should make a follow-up and say, for example, if you are in the true practice, you say that it could be metastasis, it could be budget. You need something, either you have to check the previous images or to request follow-up in this case. Let's go to another home message. And this patient, he is in breast cancer, and they did bit image for the pelvis. So what do you think? Do you see any metastasis in this patient? So maybe this is the region where the sacroiliac joint, so probably this is not hotspot, right? I agree with you. So you don't find here any abnormal uptake in this patient. Do you agree with me? Everyone agree before we shift to the other image? Yes, so that's the good answer, because you cannot see really any very high uptake like you see in the previous images. Then, surprising in this patient, surprisingly, you will find this CT image. That this CT corresponds to this bit. So do you think from the CT just that there is a metastasis or not? Hiba? Yeah, because you asked the question, so this is the answer of your question. The answer is the reverse is true. Yes, the reverse is true because the PET-CT sometimes cannot detect all the lesions and it could be metastasis. So not every hotspot is cancer and the reverse is true. And you can see the fused PET-CT image that this patient, as he known breast cancer, but there is a sclerotic lesions. And then this good interpretation, after this good interpretation, you will ask yourself, so what it could be? Why in this patient specifically, you find the lesions and sure that you will write in your report that metastasis, but there is no high uptake corresponding to this image in the bit. Anyone have interpretation for this? Nice answer. It could be treated meds, so this could be remodeling. That's the importance, Hiba, that also Muhammad Hussein, perfect, and Muhammad, that you should correlate with previous images. So this is a good interpretation that the patient have treatment. There is any other interpretation that also you can think about it and it can arise in your mind. Now we have one option that the patient received the treatment and this could be treated meds or could be active meds. So you should check for the previous images. This is good option. There is any other option? Before I answer it. Okay, so time to answer. So this patient was another pathology rather than invasive duct carcinoma. It was another pathology. So maybe another pathological subtype that it doesn't give the same appearance. So this, be aware of something called non-FDG avid metastasis. For example, there in the patient of lobular carcinoma, invasive lobular carcinoma. So it could be, as you mentioned, post-treatment or after treatment, but it could be also another pathology rather than duct carcinoma. It could be invasive lobular carcinoma. So this is the issue that you should be aware of neoplastic lesions, and there is also some categories that doesn't have FDG uptake and could be cancer as well. Okay? So this is the home message in this case. Another case of breast cancer. Try to enumerate the finding in the CT. So maybe there is, not maybe, there is left pleural effusion and anything else. Maybe there is ascites, but it's not very obvious in this case. And by the way, this is the selected image of breast. So this is the right breast cancer, and this is the pleural effusion. Yes. So at least you maybe you mentioned that there is pleural effusion and right breast lesion. But this is the importance of PET-CT in this case, that maybe there is, as you mentioned, rib lesion, but here. So there is right rib lesion. There is hot spot in the anterior acetabulum. So anyway, it will be beneficial if this patient did PET-CT, as you see. In some patient with initial staging, it could be beneficial to do PET-CT, especially if there is a present machine for this in your center or in your hospital. It will be beneficial, especially in the patient who have advanced breast cancer or they suspect for metastasis, as in this case. So clearly you can depict here and here that there is abnormal uptake that correspond to metastasis. If you go to the rest of images, clearly you will find, as you mentioned, Hiba, that there is external lesion. You will suspect that it could be also here lymph node metastasis here and here, and even in the abdominal region. So there is many lesions that it could be depicted in the PET-CT more easily than in the conventional image. That's the term of the hybrid image that arise in your mind when you make interpretation that you appearance. Zoom user left. I cannot read what you write. But I can imagine that you want to describe this lesion as left axillary lesion, probably, or left breast lesion. Okay. But you can see that. What do you think about the content of this lesion or the center of this lesion? Yeah. So this is what I want to hear, because this is a mistake that you can just say the cyst, and this is not, maybe not cyst, maybe Hussein seroma, maybe a cyst, maybe necrotic tumor. So don't rush and say that is cyst. For the cyst, you should do like ultrasound and see that is clear cyst. So don't say cyst, because in this cyst mean that it will be just like a simple cyst, or maybe cyst with tumor, maybe. But if you just say cyst, it could be like benign lesion and is not malignant. So take care. For example, after he did the PET-CT, what do you think about it? Very high uptake, hypermetabolic lesion. So when you find the hypodense lesion with wall, could be cyst, could be post-operative, could be anything, but it could be very highly avid lesion that it could be recurrence if this patient did operation, lumpectomy, or some sort of any operation. If he didn't, should be as a primary lesion. So don't rush in this, okay? So this is one of the home message. Don't rush in the CT and just say that it could be benign lesion, cystic lesion, and so on. No, it's not. Especially after you will do the rest of the image of this patient, and you can see that even the liver of this patient have multiple lesions. So this patient already, he have liver lesion. And this is also one of the good thing about the bit, that if just you look in the CT, maybe you can suspect that there is hypodense lesion here and here, but you cannot imagine that it will be with this very high uptake, and with this very high uptake and reach all this extension. right? So that's the importance. If you add PET-CT for the staging or the restaging, it could help. Also here, sometimes this lesion could be missed in the interpretation of the CT, but in the PET-CT, it will be easy for you to detect. So for example, this patient, if he missed all this and just you say that in this he have left breast lesion, you will give him, for example, T2, N0, M0. Okay, so he will be like stage 2 probably, but after you find these liver lesions, he becomes stage 4. So now the PET-CT upgrade is, yeah, upgrade the. I mean, if you miss in the CT such lesions, you will give him M0. And to be honest, when I read the history of this case, already this patient have clinical stage 2. They gave him stage 2, but after the PET-CT, he have stage 4. So this is the importance when you read it. So you have N1, M1, so this is stage 4. Okay, so carefully you should make the interpretation, and carefully you can reach the diagnosis. So again, the home message here will be proper staging. Then I wish that you didn't be bored from these cases. And what do you think about this case? So there is a lymph node metastasis in the right supraclavian region, and there is also in the right axillary. Rabab, perfect. So lymph node metastasis or lymphoma, but for this specific sites, sure that the best option that you put in differential diagnosis would be breast cancer. You know that the breast cancer staging have the supraclav and the axillary lymph node metastasis. So low axillary region is level 1, behind the pectoralis minor muscle level 2, which is the mid-axillary region, and above this level it will be 3, as you see in the supraclav and in the infraclav. So infraclav and supraclav, you consider it as 3. And finally, don't forget the internal mammary. So they like ring. The breast is one ring, so always you check for this ring. But you should also check for the other ring. So you have one semilunar ring and you have the complete ring. So in this case, sure that you go and check again for any other associated lesion, especially in this ring. So you find the breast lesion, okay, but the most important to check for the hidden internal mammary lesion. Is it clear? So for example, if you didn't detect the internal mammary, maybe you can give him N2, but after you give the internal mammary, it will be changed to N3. So it's important for you to check for the internal mammary plus the supraclav and plus the mid and lower axillary region, lymph nodes. Okay? So in this case, check for the complete ring and don't forget the small metastasis in the internal mammary. And this is the home message here that, for example, if you are interpreting the breast cancer case, so you should know the T&M staging, how it go and how they spread. For example, the T spread and the M and the N spread. For example, here we are talking about the N spread, the lymph node metastasis. And the thing that is nice here that they consider the imaging as a part of the clinical examination, as a part of clinical staging. So what you see here and what you report here in the imaging, it is one of the clinical staging that should be mentioned. And the second thing that you should think about it, that if you report it in good way, probably the patient, if he manage well, he will not have the recurrent breast lesions. That's the important if you find the lesion in the lymph node, to report it in good way, to have the patient a chance to not have any recurrence. Okay, let's go to this case. So you can see what is happening here. What is the difference between this and this and this? This is the plain CT and this is the combined bit image. So what is this? Exactly. So this is the post-treatment image. So the patient, he received the chemotherapy and he showed that there is complete resolution, complete metabolic response. This is the importance of using this term CR, complete response or complete metabolic response. That the metabolism here already like resolved here. So this means that the patient is going to be healed or he going to have a good response. Maybe in along the CT anatomical image, maybe it will be the same, or sometimes there will be some sclerosis. So this is not indicating that the patient have more metastasis or no. This means that the patient is going in good way and he's going to heal. I want to show you this case probably. Take a deep breath and so do you see any abnormality in this case? Okay. Any other suggestion? Okay. So I see that many of our stars today like to draw. Okay, good drawing. So what do you think after you see here? Now you can make the interpretation. So now you have this image and you get this image. In this image, probably I see two doctors. One of them report one here and one of them report here. And in this image, what do you write in your report? Yes? So what do you write in your report? Do you write like newly developed lesion, sclerotic lesion, or you write like sclerotic lesion in the S5 or the S1, sorry, or L5? Anyway, so what do you write in your report? What do you think about this? You write progression. So newly developed lesion, you write progression. So this is from the CT view, right? Okay. The case, it doesn't, it's still, we didn't finish this case, okay? We does not finish, we don't finish this case. Wait, okay. So go and now time to check the bit image in the first instant and the second instant. In the CT, report of the CT, the radiologist write that there is progression. But in the bit, they will write that there is yes, Hiba, Rabab, perfect, good discussion. Yeah, so regression. So now we have one radiologist and we have one from the team of the bit CT. So how we can combine the two reversed ideas? In this image, the radiologists say that there is progression, and in this image, let's say that the bit team say that there is complete metabolic regression. Yeah, Hiba, perfect. So this is a very common scenario that you should be aware of what is happening with the metastasis, that some of this metastasis can have remodeling, osteoblastic remodeling. And this is very tricky because when you, for example, just will report this image in the CT, you will write it as newly developed metastasis. That's why the importance, if you are aware of this scenario, that if come to you, in this case, go and check the previous image. And sometimes in this case, even if you check the previous image and you didn't find it, sure that you are going to say that it is newly developed lesion. Here comes the importance of PET-CT, that it helps you to detect really what is the metabolic regression from the pseudo progression. So this is what is called like pseudo progression, that the patient have pseudo progression, is not true progression. He already have healed sclerosis, and this just the remodeling after this lesion just healed, and there is remodeling instead. So this is the importance that you know that this patient have what is called complete metabolic response. There is another pitfall called metabolic hyperplasia or flare phenomena. There are two phenomena that can happen. I hope that I can show you. I think here probably. Yeah, check for the bone. Don't see that what is happening in this patient, but check for the bone in this patient. You will find probably that there is some increase in the background. Sometimes it is more obvious than this, and I think I can have one more better image. Let me check. It's called like bone marrow hyperplasia or flare phenomena. Okay, so this is another example. So from the what happened with you in the tricky case, last tricky case, what do you think about this patient going in progression mode or regression mode? his patient in regression mode, exactly. So you can see that this focus, now it being resolved here. In the other side, maybe you can see that there is some hyperplasia in the marrow. And if you go to check the same patient, the same vertebra in the CT, if you go here, compare this one with this one, in the CT you are going to tell that there is pseudo progression, that there is newly developed lesion. But the truth is that what is happening here, that this patient have, maybe here he have like more obvious metabolic activity, but finally he have complete metabolic response. Then if you compare this one with this one, you can note that there is increase in the metabolic activity here, right? This is what is called flare phenomena, that sometimes after the patient receive the treatment, he can have, there is increased activity, but this probably is not real. That's why you should do the PET-CT lately, that to avoid this what is called pseudo progression, even in the early stage of the treatment. Is it clear? So this is the full picture of this patient, that he already going to be with complete metabolic response. So this means that he is in good way here. Is it clear? So this is the importance in the home messages, that you should have, or you should know, that there is something called complete metabolic response, and there is something like bone marrow hyperplasia or flare phenomena, which is increased after the treatment. Also, the most important to check previous imaging, and if you find a sclerotic lesion or lytic lesion, maybe the sclerosis happen as a healing process. So check carefully, especially if this patient have, yeah. I wish that you enjoy the session. We have maybe I was planning to, we can make voting. I was planning to continue in our cases after we finish this presentation. So we can make voting if you would like to continue for maybe 20 minutes or to stop in this point. Okay, inshallah, we will continue. we make this review continuation, inshallah, of the cases. And there is good news. We mentioned already in the last session about the FR, that it will be online. So you can just start to have the review, start to check if you can have the chance to enter the exam, and you could have benefit from this revision, inshallah. Yes, Ivan. So what is the title for this case? How we describe it? Nice answer. Subperiosteal reaction along the radial aspect of the middle phalanges of the index and middle fingers. So radial subperiosteal resorption. Can you try to draw it? And you will mention that there is no evidence of erosions or brown tumors when you suspect hyperpara with the subperiosteal reaction or resorption. With the subperiosteal resorption, you will search for any brown tumors. So you will say that no brown tumors. So you will check the radial aspect of the middle phalanges. Of the index and middle fingers. And you will check for any terminal phalanges, terminal tufts, bone resorption. And if you have any chest X-ray, you will check for the distal clavicle to check for the lysis. Let's have a look in this appearance. So you're going to check the distal clavicle for any lysis or any resorption. And in the skull, you are going to check for skull. There is trabecular resorption, so what is called paper pot skull, trabecular resorption. So you can see that there is lacunae inside. And they like in the MCQ to check something called floating teeth, lamina dura of the skull, and the teeth producing what is called, the image is hazy, sorry. I'll try to make some modification. I hope that it can be more clear. Still, And as you see in the humerus here, there is lytic lesion and it have associated fracture. So this is what is called brown tumor. So you check for any brown tumors and any associated fractures in hyperpara. And if you get this scan, so what is going on here? Already the image here is hazy. So what do you think about this? Yeah, there is adenoma. So there is retained tracer in the right parathyroid adenoma. So this is the early image around 10 minutes, and this is the late image around 90 minutes post injection. So when you find this remaining tracer, this is what is called systemibe scan, and this is what is called retained tracer in the parathyroid adenoma. What do you think about this? Yes. So diffuse cerebral edema, effacement of the sulci and the gyri, the gray-white matter interface almost lost, and there is loss of the normal junction between the white and the gray matter. Just the spared here, the cerebellum and the brainstem. So this is what is called the reversal sign, above perfect white cerebellum sign. So this means that you have critical, severe hypoxic ischemic encephalopathy near mean, perfect. So this is the title of this patient, reversal sign. So this means that this patient have a reversible brain damage and probably very poor prognosis. Spot diagnosis. Yeah. The first thing that you should comment, if you see it, the endotracheal tube, yes, in satisfactory position. There is in the right hemithorax lesion, lucent lesion, and the most important to mention that there is mediastinal shift in the contralateral side. You will check the hemidiaphragm could be visualized or not. So in case that you didn't see it, you are going to mention that it could be congenital diaphragmatic hernia. Perfect. Above. And the differential will be the C cam. the cystic adenomatoid malformation, and Bogdalic in the back, 90% of congenital diaphragmatic hernia. Morgagni will be in the right, as the heart prevent development in the left side. Yes. So again, when you check this patient, you will start with, yes, the nasogastric tube. So it is lower end in the stomach, so it's fine. You check for any other lines. For example, if there is any umbilical catheter. Then after that, you check what is going on in the lung. The first question you ask yourself when you see chest of neonate, you ask yourself, is it small volume or good volume? So according to this question, you can resolve if you are talking about hyaline membrane disease or something else. So it looked like a small volume, probably, and the granular appearance affecting both lung, more in the right side with air bronchogram. You will check the history, and you know that the hyaline membrane disease is the most common cause of respiratory distress in newborn. The good question about the volume, you want to check if this patient premature or not. So if he is premature, you are talking about hyaline membrane disease. They like it in the MCQ as a common scenario in the exam. And the most important to check the complication if you are going to tell that this patient has hyaline membrane disease, to check for as a complication you check for pneumothorax. You know that this patient will receive like ventilation therapy, so there could be a complication from the ventilation, and there could be pneumothorax. Or also there is another example with this patient after he received the ventilation therapy, and you could find maybe some bubbly appearance reaching even the periphery. So this could be interstitial emphysema. So pulmonary interstitial emphysema. Yeah. In the image, if you want to check if this patient is premature or not, try to find any key as you check for the humeri, the humeral heads, if they are ossified or not. So absence of ossification, this could suggest for you that this patient is premature. And also if there is reduced fat, subcutaneous fat, going to be with the premature.